Good afternoon, good morning, good evening, wherever you are logging on from. Welcome to our February version of the Australasian Pro Seminar. Today we have the honor to have Professor Stefan Marciniak from Cambridge University and Edinburgh Hospital in Cambridge to talk to us about genetics in pneumothorax. Stefan, as far as I know, was the first person to start having pneumothorax clinic, and he's published lots of papers in genetics and is no question in my mind the best person to talk about this from the whole world. So without further ado, we'll pass the stage to Stefan to talk about genetics of pneumothorax that clinicians need to know.
Great. Thanks, Gary. Thanks for that very kind introduction, and thanks for everybody for turning up for this talk. If I look a bit tired, it's because it's 5 o'clock in the UK at the moment, 5 a.m. And I've just got up to give this talk before my clinic starts in a couple of hours. So I'm going to start. I've got about 15 minutes to talk to you about pneumothorax and genetics and try to excite you about this and perhaps allow you to make some diagnoses that you didn't know were there lurking in your clinic. This is going to be my general overview, and which was taken from a review that one of my students wrote a few years ago. I'll keep coming back to it, but just as a sort of to orientate you for the rest of the talk. I see lots of pneumothoraces. All the pneumothoraces in East Anglia are sent to my clinic, and I do get some unusual patients with unusual presentations sent to me from across the UK. It's worth remembering that about 10% of your pneumothorax patients will have a family history, a first or second degree family member who's also had a pneumothorax. And when I'm sent for patients with second opinions, it's remarkable how often nobody has actually looked into this and asked about their family history. So please make sure one of your questions is about pneumothorax, family history. And then when I ask students in clinics, tell me about the most common genetic cause of pneumothorax, every single time, everyone says Marfan syndrome. And every time I put my head in my hands and say, no. Marfan syndrome is one of the causes on the list, but it is not. There is one that is far more common that I'll talk about first of all. If you're trying to get your head about how to remember these cases, group them into those that have defects of mTOR signaling. So you have to remember some of your first year biochemistry. Those that have defects in the extracellular matrix, which do include things like Marfan, people like Marfans. And then there's a whole group where we currently can't get the diagnosis, and that's where it's a great opportunity for you and us to do some research because we're still finding new syndromes. So I'll start off with a sort of a typical case. This is a patient who was actually working as an English teacher in the Far East for several years. And she came back to the UK and had a pneumothorax in her 60s. She was a non-smoker, so this was not classical secondary pneumothorax. She'd actually told me she'd been having pneumothoraces for 15, 20 years where she had been working and had surgery. You can see from her chest x-ray that there is some pleurodesis at the apex, but she's got a slightly loculated left basal pneumothorax. And she'd also had a contralateral pneumothorax. She said to me immediately, with a smile, she said, "Oh, you won't be able to tell me what's going wrong with me because this has been going on for 20 years. So the first thing I did is I took a family history, and it was very dramatic that she has a dominant family history. Her brother had pneumothoraces in his 40s. Their mother had pneumothoraces in her 60s. Their maternal uncle had pneumothoraces in his 60s. So this is clear-cut familial pneumothorax. The CT scan, to my mind, made the diagnosis immediately. So when she said to me, "You won't be able to tell me what's going on," I immediately said, "I'm pretty sure I can." And this is before we did the genetic testing. So again, I'll give it away in a moment, but this CT scan, burn this CT scan into your mind, because this is the one that's going to make the diagnosis for most of the genetic diagnoses you make. This person has lots of cysts. They're in the lower part of the lung, not spread throughout the lung. She doesn't have the usual apical blebs that you see in those typical tall, thin young boys that come to your clinic. They're irregular cysts. They're not the nice round typically symmetrical cysts that you might see in your patients with LAM, lymphangiomyomatosis or atypical or even atypical emphysema. But so this makes a diagnosis, which I'll give away in a second, and then examining her confirmed it. So looking at her face, she had these little tiny white papules, which are called fibrofolliculomas. She'd barely ever noticed them. They just look like little whitehead spots. In some patients, they can be very large and disfiguring, and in some patients, they can be completely absent. And it is said that patients from the Far East are less likely to have them. And this particular syndrome sadly is associated with kidney cancers. And when we performed an MRI scan, she already had a renal tumour. So this diagnosis, some of you may have already clicked, but don't worry if you haven't, is called Birt-Hogdebay syndrome. It is easily the most common genetic cause of pneumothorax. So Marfan's does happen very rarely. This happens in half of the cases that I see when I make a diagnosis. It's a dominantly inherited condition. It's caused by mutations of the folliculin gene, the FLCN gene, and when you make the diagnosis, almost when you send off the genetic test, it almost always gives you a clear answer within 2 or 3 months, how long it takes to come back in the UK. These patients, as with many genetic disorders, not every patient has every feature. So 90% of patients with this condition will have lung cysts, and they tend to be in this basal distribution. Half of the patients will have a pneumothorax, and these cysts and pneumothoraces, they tend to be diagnosed in midlife, well, not midlife, early midlife, so 30s, 40s. 90% of people are said to have these skin changes. They're called fibrofolliculomas, they're benign tumours. In some patients, particularly some of the men, they can be quite disfiguring and need to be removed, but often you don't see them. But 25% of these patients can get kidney cancers. The kidney cancers tend to happen typically 10 to 20 years later. So the reason you want to make this diagnosis isn't simply so you can tell your patient why he or she has got a pneumothorax. It's to save their lives, because if you then arrange imaging of their kidneys every year, you will identify these tumours when they're small enough to be cured. So if they're typically, if these renal tumours are less than 3 centimetres, your urology colleagues can remove them by a partial nephrectomy, leave most of the kidney, because they might develop another tumour in 5 or 6 years' time, so they don't tend to take the whole kidney out, but they can cure them. Unfortunately, when they get to above 3 centimetres, as happened in this case, they tend to have metastasized. So she sadly passed away a year later of metastatic disease. This tumour was completely asymptomatic. I suspect that if we'd been able to make the diagnosis, if we had seen her during those first pneumothoraces, rather than her being looked after elsewhere, we would have enlisted her in renal surveillance and may have helped. But what we have done is we've screened her families, and we've identified many, 50% of her relatives have the same condition, because this is dominantly inherited, and they all now have annual MRI. We do MRIs rather than ultrasounds in this particular case because the renal tumours are a little bit unusual, and they can be sometimes invisible to echo. So ultrasound. So if you can get annual MRIs, that's superior to ultrasounds. Ultrasound is better than nothing. If you look at the textbooks or something like OrphanNet, you'll say, oh, he's talking nonsense. This is 1 in 200,000 of the population, 5 per million. Why am I bothering? Sadly, those textbooks and OrphanNet is currently wrong. When we looked at we published this last year, when we looked at 3 large databases, UK Biobank is 500,000 supposedly healthy people. And we found that 1 in 4,000 of these healthy people have Birt-Hogdebay syndrome genetically. If we look at the healthy patients in the 100,000 genomes, 1 in 2,000. Now, both UK Biobank and 100,000 genomes are quite biased towards Caucasian patients, but the East of London Genes and Health cohort is largely of Asian background, and in those cases it was about 1 in 1,500. So I think if you say as a rule of thumb, this condition is not 1 in 200,000, it's more like 1 in 2 or 3,000. So it's 100 times more common than you've been taught at school. So please, please, please diagnose it. So this is the most common. If you forget everything else I'm saying to you in these 15 minutes, please remember Birt-Hogg-de-Bay syndrome. The next condition is LAM, lymphangioliomyomatosis. Yes, it's not normally inherited, but in patients with tuberous sclerosis, about 30% of the women will develop LAM. So when you diagnose a patient with LAM, so these women, they're almost always women, will have these small cysts spread throughout the lungs. It tends to get worse during pregnancy. It's a condition that's seen during childbearing ages, so from menarche until menopause. And it can be associated with tuberous sclerosis. This patient is the photo I've taken, not one of my patients, has quite florid facial angiofibromas. But if you do see these tumours, they help you make the diagnosis of tuberous sclerosis. These hypomelanotic macules are also seen, and then there is the chagrin patches. Rarely you'll also see these paraungual fibromas in both the hands, but also look at the feet. These patients can get tumours of the kidneys, which tend to be benign, but they can grow and cause problems, and the urologists have to treat them. But they also can have tumours forming in the brain. So many of these patients develop epilepsy, and some of them have learning difficulties. So that is mTOR signaling. The thing that you normally think, or most students think of, is Marfan syndrome. Marfan syndrome is a hard diagnosis to make because there are lots of tall, thin people who don't have Marfan syndrome. So you need to have the Ghent criteria, the modified Ghent criteria. They're really complicated. Print them out or have them on your phone, because even I see these patients all the time and I can't remember all of the conditions. So I need to have a printout. You get more points for having a major feature, and you get some points for having a minor feature. For example, an aortic dilatation is a major feature, pneumothorax is a minor feature, but it does give you 2 points. These patients have arachnodactyly. Arachnodactyly doesn't just mean having long fingers. When you look at them, you can do some clinical signs. Oops. So Steinberg sign, or the thumb sign, is when you adduct your thumb across the palm and then make a fist about it. Now, I can't see my thumb when I make a fist over it, whereas this patient was able to push her thumb out of the fist. If you can see an interphalangeal joint, that is a positive Steinberg sign, a positive thumb sign, and that is a very specific test for arachnodactyly. And so that is a useful sign. Another sign, the Murdoch-Walker sign, is can you put your little finger and thumb and touch them around your wrist? Many slim people can do that, so don't worry if you can do it right now. But people in whom it's positive can even sometimes overlap their finger and thumb. So Marfan syndrome, it's not that rare, 1 in 5,000, and 10% of them may have apical blebs and develop pneumothoraces. They too tend to have arachnodactyly and often chest wall deformities, so pectus carinatum, pectus excavatum. Sometimes they may just have very asymmetrical chests. The reason we're making the diagnosis, though, is not to tell them why they've had pneumothorax. It's because that about 30 of them will later in their life, 30% of them will need surgery for their aortic roots. So you will save their life by arranging them to have an annual echocardiogram. A similar but rarer condition is Loeys-Dietz syndrome. And one of my team, we wrote up the first case of a patient presenting with Loeys-Dietz through pneumothorax. It's about 1 in 10,000, 100,000 patients, and it can be caused by mutations of any of the genes involved in TGF-beta signaling, from the ligands TGF-beta 2 and 3 to the receptors 1 and 2 and some other transcription factors. Initially, when it was described in the early 2000s, these patients had hyperteliorism, so widespread eyes, cleft lip, so midline fusion defects, and arterial tortuosity. So they can have arterial abnormalities in the brain all the way down to the popliteal vessels. And they can have complications during pregnancy. we've found that it can be quite mild. It doesn't have, you might look at the person and they may look slightly morphanoid, tall and thin, but the evidence of the midline fusion defect can sometimes be the failure of the bifid uvula, failure of the fusion of the uvula. So look in the back of their throat, and if they have a bifid uvula, that suggests that they may have Loeys-Dietz syndrome and a midline fusion defect. These patients need careful monitoring. They need annual echocardiograms, but every few years we do whole body magnetic resonance angiograms because they can develop aneurysms in their brain all the way down to their legs, and you can save their life surgically. And the final one in this whistle-stop tour I'd like to talk about is vascular Ehlers-Danlos loss. Again, quite rare, but an important diagnosis to make. About 5 cases in a million. But it's got a very high penetrance. If you have a defect, if you have a mutated collagen 3A1 gene, about 80% of these patients will have had a life-threatening complication by the time they're 40. And that life-threatening complication can be rupture of any hollow organ, from the lung to the uterus to the bowel to a blood vessel. So we make these patients tend to be very flexible. Their scars can stretch. They tend to be able to stretch their thumbs, hyperextend their tongue. And the thing to do is when you see a patient with pneumothorax in your clinic, I do this for everybody just so I don't miss somebody, is do a Baton score. Our rheumatology colleagues do it all the time. It takes about less than 1 minute to measure how hypermobile somebody is. They get a point for touching each thumb to their forearms. They get a point for touching either knee, for a hyperextending either knee and then either elbow. So that's 1, 2, 3, 4, 6 points. If you can hyperextend the little finger more than 90 degrees on either hand, that's another point for each hand. And then if they can touch the ground with their straight legs, but they only get the point if they put the palm flat on the ground. Some of these patients are so hypermobile that they'll put their elbows on the ground. But this is if they have a normal patient, a young, flexible patient might have 5 out of 9. That's okay. Above 5 is hypermobile. And these patients are important to identify because they get repeated ruptures of vessels, ruptured organs. And this is one of my patients who had multiple bleeds into the lung. And for all the world, this looks like a vasculitis at first glance. You see these moving cavities. Here's a nice cavity here, small cavitating lesions here, evidence of local bleeding. Most of these patients are thought to have vasculitis, even though their vasculitis screen is negative, until you biopsy the lung. And then you find no vasculitis, but you see hemosiderin-loaded macrophages and areas of local fibrosis. And that's because they've had recurrent bleeds. These patients need careful monitoring because you want to prevent them dying of a major vascular catastrophe. So nearly finished. In my clinic, because I live in a sort of a university town, my clinic ages are biased heavily towards the young, tall, thin young patients. But the familial cases tend to present at any age. One of the curious things we've observed is if you've got familial pneumothorax, you tend to recur more quickly than if you have sporadic pneumothorax. Even if we don't make a genetic diagnosis, those patients tend to recur more quickly. When one of my students, Hannah Grimes, analysed about 400 of our cases, she confirmed my feeling that the most common diagnosis in my clinic is Birt-Hogg-de-Bay syndrome. Marfan's is there, followed by Ehlers-Danlos loss, Loeys-Dietz, and then some rare things. In the UK, again, Hannah was the student. We designed a gene panel. This is the R190 gene panel, which has now become the standard NHS test for pneumothorax genetics. But almost always the result that comes back is folliculin because it's the most common cause in even other labs around the UK. But this test is now a standard test. It takes about 3 months for the result to come back because they have to sequence 10 genes. Okay, so that was a whistle-stop tour through pneumothorax genetics. If you have any questions at any point in the future, just email me on my NHS email. If you want to, I know that Gary's still on X Twitter. I've moved over to Blue Sky. So if you want to have a chat on Blue Sky, please do. And I will stop talking. I can't hear you, Gary.
Yep, yeah. Sorry. Yep. Thank you very much, Stefan, for a very thorough talk on the genetics. And it reminds me of the one person that I missed the diagnosis of vascular ehlers-Danlos, and she did have a significant event later on, and I haven't forgotten about that. If anyone has any questions, as usual, please put it on the chat, and then we'll talk about that. So, Stefan, I'll start off. How long or how old would we follow those patients with Burke-Hogg-Dubé? Do you follow them for life?
Yeah, so the Burke-Hogg-Dubé patients, I don't follow them in the respiratory clinic. We always used to say that their lung cysts don't progress, but we're now beginning to wonder if that's true. Rarely some of that, but they don't seem to usually come to harm from the respiratory point of view. But all of the Burke-Hogg-Dubé patients, I refer over to the Renal Cancer Genetics Service, and then they get their annual screening for the rest of their life. As we saw, the patient that we had there was 68. So I think we have to image their kidneys annually, lifelong.
And at what age do you think these cysts in the lungs actually develops? We have, yeah. So since we have been screening, we have found children of our patients who are then genetically tested positive, and then I guess out of academic reasons, even though they haven't had a pneumothorax, we did scans a few of them, and they have no cyst in the lungs. Yeah. What do I do now?
So the simple answer is we don't know, and the reason in the UK we don't do genetic testing on children until the children are 18, because the idea is only do a test if it changes what you do. And we don't CT scan the children. So it's interesting that you've done those cases. You probably should write those up because we don't have imaging of children.
No. When I say children, they're not young children. They're young. Okay. They're the children of the
adults. Okay, yeah.
The adult children.
The penetrance, I said, is 90%. So we know that 10% of patients with Burke-Hogg-Dubé don't develop the cysts, even in one family. That does not affect, though, the risk of the renal cancer. So you're going to still be following them up, or somebody's still going to be following them up from the renal cancer perspective. When the cysts develop, we don't know whether the children have them because we don't scan them. We don't do genetic testing on the children until they become 18. And very recently, I had a family in clinic asking me about their children, and I said, well, we have to wait until the children are adults before they can decide about testing. So I used to say the cyst didn't change with age, but there is a nice case, as a nice image in chest, of one in Holland where they tend to do lots of repeated CT scans. I don't do, and they follow the same patient over many years, and the cysts progressively worsened. Which is why I say that although we used to think the cysts were probably developmental and stayed for life, I now suspect that there is progression with age. So your patients who currently don't have cysts may develop cysts in the future. I wouldn't personally CT them again. I would simply say you have a 50% lifetime risk of pneumothorax.
Right. We've got a couple of questions on the chat. So the first question is, should we CT scan everyone with pneumothorax, even in the first episode?
Good question.
Or only with family history? Yeah.
I don't. I tend to CT everybody with unusual features. So the tall, thin, young 20-year-old who has his first pneumothorax, I don't, because it's probably not going to change what I do. I always CT, but all of the female patients I CT, because if you don't, you're going to miss lamb. Also, because females are much less likely to have any spontaneous pneumothorax, proportionally, more of them have got genetic disorders. So follicular and tuberous sclerosis, there's no male-female bias. so the equal numbers of males and females have it. But because so few females have pneumothoraces, proportionally more of them will give you a genetic diagnosis. So I CT scan. I don't CT scan the tall, thin young boys on their men on their first pneumothorax, but all the others, the people with a family history for sure, the women for sure, the second occurrence for sure, and also, although it's not genetic, all the cannabis smokers because they've probably got bong lung.
I think if you look at different guidelines in US or UK, you can find guidelines that support doing it the first time or not support doing it the first time. So
Yeah.
we tend to offer the patients to say, if you want a CT scan, we can organize it. And
Sure.
I think
Well,
probably
with low
more,
dose CT scans, the radiation dose is coming down very
yeah,
soon. Very soon, ultra low dose CT scans will be similar to a chest X-ray, and then
that's right.
it doesn't matter.
Yeah. Another question: Who do you refer patients with Burke-Hogdobay syndrome for eye assessment?
Birt-Hogg Bay, no. So not
Yeah.
eye assessment. Usually usually it's just me and the genetics department because I can make the diagnosis and the geneticist can follow them up. The occasionally the dermatologist, but usually the skin changes are easy. I'm not aware of eye problems in Birt-Hogg Bay. Marfan syndrome for sure, and Lois Marfan syndrome, yes.
Yeah. I think that was because there's one or two case reports from some American ophthalmologists who said that there's eye conditions, but I think
Yeah.
it's probably likely to be just a casual association rather than a causal
Yeah.
associations. But
Yeah.
some of our ophthalmologists then become very excited and wants to scan everybody with the
Yeah.
Hogdobay syndrome. But
Yeah. I've never
it's
seen eye problem. I've never seen eye problems with Hogg Bay, but I'm very happy to be educated.
right. Now, what do you do with the ones that you don't find to have any, might have a family history, but no genetic abnormality on your testing?
We looked into a lot of. So we accumulate. So about two-thirds of the frustratingly, when you get the patients with a family history, two-thirds of them will not have an obvious monogenic cause, and so a third of them you'll identify Birt-Hogg Bay, Marfan's, Loistes. The two-thirds, when the genetic testing is negative, usually you can stop because it's probably polygenic, and we're just not good enough yet in terms of genetics to identify polygenic causes. But sometimes when there are when there are unusual features, we will progress to whole genome sequencing, and we've published a small number of interesting cases. So one patient was referred and had a filamin A mutation. So filamin A, it tends to cause in women cardiac defects and epilepsy. The boys you don't see because sadly they die at birth because of lung developmental problems. What we've discovered and others is that those women can have quite severe congenital emphysema and only realize when they have a pneumothorax. So women with epilepsy and cardiac defects think about filamin A. And we've just had accepted for publication a new case where we identified by whole genome sequencing a DNA methyltransferase mutation, DNMT3A, which is Tattenbaum-Raman syndrome. That's patients who have very, very tall, have some minor intellectual disability and pneumothoraces, and we've now linked that to pneumothorax. So most of them, if you don't make a genetic diagnosis from your gene panel, most of them can be discharged and reassured that it's polygenic. And the polygenic cases don't appear to be associated with long-term risks. But obviously, we'll be open-minded as the years go by.
Do you think all these weird and wonderful defects that we discover from pneumothorax genetics would teach us anything about how other lung conditions or cystic lung conditions develop?
That's a really good question. So so for the Birt-Hogg Bay, we will understand an awful lot more about lung mechanics once and development once we understand when we finally understand why the cysts are in the lower zones. So there are many theories. And that's actually an area of research. We know that these patients develop lower zone cysts, but we don't know why. So I think studying that condition will. I also think that studying these rare conditions, the more you study rare conditions, the more common you find they are. So
Mm.
initially, Birt-Hogdebay syndrome was this curious condition that only affect 5 per million people. We now say it's 1 in 2,000, 1 in 3,000. There's this startling statistic that 1 in 17 people have a rare disease. So as a group, rare diseases are quite common. It's just any one of them is individual. But I think studying the mechanics, we understand about cyst formation more by studying the connective tissues of patients with Marfan syndrome and Loeys-Dietz syndrome from a developmental perspective, and then perhaps that will inform our understanding of patients with COPD and other normal cysts. But I also think that there's so much of the biology, 2/3 of them we don't understand yet. So I think under the next the youngsters on the call at the moment during their careers, I think genetics will move to understanding the polygenic risks, which currently I'm too stupid to understand.
Well, I think this is a good time to stop. We are just about over time. So thank you so much, Stefan, for a very interesting talk. And I'm sure we all will go home and think a lot harder for the next patients that we see with primary pneumothorax.
Right.
So thank you for getting up so early to talk to us. Thank you very
Always good
much.
to see you, Gary. Bye-bye.
Thank you.
Bye.
Bye.